Well, when it comes out, it'll come in. All right. So for today, we are going to start off by talking about myasthenia gravis, and then we are going to finish alpha and beta today. There are some things that I am not going to be going over, just because they're either a little bit more straightforward or I just don't think I'm going to have time. Um, Things like varenicline or Chantix, I just won't go into, but it's kind of a one-off drug. Um, I'm going to talk about myasthenia gravis because um, it is it's a really interesting condition and a test that we have. So I think that'll be a good place to start, and then we'll jump into adrenergic stuff. Just to be really, really clear as well, because I realized that this wasn't something that I said yesterday, but when we talk about the parasympathetic nervous system, okay, we know that we have uh, preganglionic and postganglionic receptors, right? And acetylcholine is released preganglionically and postganglionically. And the receptor in the parasympathetic system we talked about are muscarinic receptors. One of the words you will hear tossed around all the time talking about these drugs is drugs that affect the parasympathetic nervous system. They're called the agonists, can either be called muscarinic agonists or you'll hear cholinergic drugs. You'll hear one or two, right? And essentially these are talking about the same thing. Cholinergic is just referring to that they mimic the acetylcholine on the muscarinic receptor. Also, are my birds too loud in the background? Is it distracting for people?
Not really.
All right. Let me give them a piece of candy so that way they're quieter. And if that doesn't work, I'll just throw them in the oven. I'll have chicken dinner.
Sounds delicious.
All right, you little fuckers. Here's some candy. They want to go into their bedroom, that's why. But I won't let them in there. No. Go to bed. All right. So, if you hear this word cholinergic or muscarinic agonist, we're talking about the same thing. Likewise, if we're talking about antagonist, obviously we're talking about muscarinic antagonists, but you'll also hear the term anticholinergic. And these are talking about the same thing. So we're blocking the muscarinic receptors with the drug, or we're having an effect that looks like we are blocking the receptors with the drug. So don't get confused by the term cholinergic. We're just talking about the parasympathetic nervous system. So with that in mind, what I want to jump into today is talking about a autoimmune condition called myasthenia gravis. Myasthenia gravis is an autoimmune condition where the body destroys nicotinic receptors on the body destroys nicotinic receptors on the neuromuscular junction plate. Okay, so the body destroys these nicotinic receptors where the nervous system comes in and innervates the skeletal muscle. What this means is that we have less nicotinic receptors on skeletal muscle to control. Just now, one of the things that can end up happening, and let me just pull up a diagram. And nope. No. All right. So one of the things that can end up happening with myasthenia gravis is that you end up getting this myasthenic crisis. And what ends up happening is that a myasthenic crisis is an exacerbation of the general symptoms that someone with myasthenia gravis would see. And so this would be things like weak muscles. You'd have difficulty standing. And as you get more and more severe, you end up having things like respiratory failure because the diaphragm has less control by the nervous system. What's important to understand is that this is inducible. So a stress is going to cause an increase in the immune system function, which ultimately causes an increase of the nicotinic receptor destroying. So just like when you guys learned about sickle cell disease, when someone with myasthenia gravis has a surgery, or they have an infection, or they're significant amount of exercise, or they get too hot, they can go through a crisis where all of a sudden they can't move their muscles. And it can get so bad that they end up failing to be able to breathe, which is no good. One of the things that we often see with them is a failure to be able to flutter their eyelids. And that's really the one of the physical exams that we really look for with them. The muscles that control the eyelids are the smallest muscles in the body, and they're most likely to be affected by this ptosis, or the drooping of a body part. So the way that we treat, or the way that we test to see if someone is in myasthenic crisis. So a person arrives to the ED, patient comes to ED, and they say, I can't move. Well, that's not good, because they could have something like Lambert-Eaton syndrome, which is a much, much different condition than myasthenia gravis, has very, very similar, looks very, very similarly, but they have two completely different treatments. And if you treat one the wrong way, then you end up really hurting the person. Lamborghini, yeah. So what we end up using is a cholinesterase inhibitor to test for myasthenia gravis. So in myasthenia gravis, the clinical the pathophysiology in myasthenia gravis is that we have too few nicotinic receptors. There's too little. To treat this, we can either give more nicotinic receptors, right? Replace what was gone, or increase the stimulation on remaining receptors. Now, we do not have a drug that replaces the nicotinic receptor. We can't give them nicotinic receptors and all of a sudden they get better. So this is not a possibility. So what that means is that we need to increase the stimulation, which amounts to us increasing levels of acetylcholine. So normally a acetylcholine would get released in the synapse. It's going to bind to the nicotinic acetylcholine receptors, and we end up with skeletal muscle movement. This is what should be happening normally. What is also in the synapse is acetylcholinesterase, which will break down our acetylcholine into inactive metabolites. So if we give an acetylcholinesterase inhibitor, this is going to raise levels of acetylcholine, meaning that even though that there's few receptors, we're trying to increase the total stimulation of the remaining receptors. So a acetylcholinesterase inhibitor raises acetylcholine levels because we're turning off the destructive pathway. So no acetylcholine destruction means that we can provide more stimulation. Any questions about this? All right. We refer to someone who responds positively to this sort of treatment. So I believe you guys learned this as the Tensilon test, which, does anybody remember which drug is Tensilon? Edrophonium. Very nice. I almost wrote the wrong one. And do you guys remember what the purpose of edrophonium is? Don't overthink it.
To see if someone's in the cholinergic crisis or the myasthenia crisis, something like
Yeah,
that.
exactly. So we give edrophonium, and what we're going to do is we're going to inject this into the body. We're not going to give it orally because we're in an emergency situation. And what we're looking for is the response on muscle strength. So if their strength improves, this is a positive tensilon test, and we have myasthenia gravis. If you give tensilon and your muscle strength worsens, then we probably have muscle weakness due to some other cause, which is probably a cholinergic issue. So on the exam, the big thing to remember is the tensilon test is positive if your muscle strength improves. If it gets worse, you are in cholinergic crisis, right? And then we're just raising levels of acetylcholine, which is going to make things much, much, much worse. Not great, right? Not great at all. Side note, so the treatment for myasthenia gravis long-term is to use the acetylcholinesterase inhibitors, also to use immunosuppressants. It's an off-label, so like glucocorticoids. The ultimate treatment for myasthenia gravis is thymectomy. So they remove the thymus in order to, get rid of those T cells, which are causing so many different issues. In cholinergic crisis, which is where you have too much. Sorry, this is like a separate point. Let me put this down below. In cholinergic crisis, you have too much acetylcholine. And you guys learned about that this could be due to a workplace hazard like organophosphates, which we know is almost a natural poisoning because of farmers. Or maybe you overdosed on your acetylcholinesterase inhibitor, which can sometimes happen with people with Parkinson's, because we do give acetylcholinesterase inhibitors to people with Parkinson's. And so what is the treatment going to be for cholinergic crisis? So you have way too much acetylcholine. Exactly. So the problem is too much acetylcholine. So we give a muscarinic antagonist. And we give a pretty broad one like atropine. 2-pralidoxime, 2-PAM, is only for organophosphate or like sarin gas. warfare. So you don't really see praladoxime outside of like the Midwest, where people are not farming, that sort of thing. Any questions about this stuff about myasthenia gravis? Was this helpful to go through this? Because it was one thing I just did not understand going through this course. Okay. All right. Let's jump into the good stuff. The first thing that I'm going to tell you about adrenergic drugs. If there is one thing you should take away from tutoring, is bean. Please remember bean. Okay? First of all, does anybody know what bean refers to? I don't know why people don't tell this. Epi goes to beta. Norepi goes to alpha. Okay? Beta is epi, alpha is norepi. Bean. Okay? This is an incredibly helpful acronym for understanding where these neurotransmitters are going. I constantly forget, and I have to say to myself, bean. It's all bean. Bean. So this should be well. I know, mind blown, right? Gotta love beans. Great. So when we talk about the beta receptors, in general, what we can say is that, whoops. In general, what we can say is that beta 1 is primarily in the heart, whereas beta 2 is primarily in the lungs and the blood vessels. You end up having an overlap with beta 1 where you do have some kidney involvement with beta. Oh, he talks about beta 3. Okay, yeah. We'll talk about beta 3. Okay. And and then one of the big complications that we see with beta 2 later when we talk about it is specifically in the liver. And then we'll talk about beta 3 in a second. So let's jump in and let's talk about how all of this works. Starting with beta 2, just because I find it to be a little bit more interesting. Like we talked about yesterday, beta 2 are GS GPCRs. And what ends up happening with the whoops. Sorry, give me 1 second. I just want to find my chart that I had. There we go. Did he talk about with you guys about nitric oxide with beta, or did he skip that? Did he talk about with alpha or no? Oh, okay. All right. So, like we talked about yesterday, where we find beta 2 specifically is really on the smooth muscle surrounding luminal areas. And I have a really, really good diagram that I thought I pulled up. But apparently I just deleted it. Ah, here it is. And essentially what ends up happening is on our smooth muscle, we have our nice beta 2 receptor, which is connected to the GS subunit. Just like how we talk about with everything in terms of camp, what we really care about is how the interaction of the oh no. Sorry, everyone. I'm just getting all my wires crossed. Let me go back to this guy. Beta. Okay, I did have it right. Sorry. I just want to make sure that I'm not giving you guys the wrong information. Like we talked about yesterday, what ends up happening with GS is that it's going to stimulate adenylate cyclase, which will convert ATP into cyclic AMP, which what is specifically happening in terms of the lung is we end up getting the inhibition of contraction. Which ultimately looks like relaxation. Right? So what ends up happening with the beta 2 receptor is we end up getting the luminal area of the luminal area increases. So we end up having dilation of the bronchial airways. And then we also end up having dilation of the blood vessels. I feel like I'm missing something. There's something I had something for you guys, but I just cannot remember where I had it. All right, let me pause real quick. Let me back up. All right. Where we find beta 2 is on smooth muscle. Remember that when we talk about smooth muscle, what we're specifically focusing on is the role of calcium. Right? When we went through and we learned about how the muscle contraction is made, calcium is a major component of what allows the cell to make that muscle movement. So let's look at specifically what happens with calcium. We have two important structures. We have the sarcoplasmic reticulum, and we have the myosin light chain, which kind of looks like this. So we have the myosin head. If you remember, one of the things that happens is that when the myosin head is activated, it gets stuck with this phosphate group on it. And when that phosphate group is stuck onto the myosin head, this is where a muscle movement happens, right? The stroke of the muscle movement occurs. So this is what normally takes ATP, and it's through a specific enzyme called the myosin light chain kinase that we end up getting the muscle movement that we're going for. So it's through this process that we have a contraction. What ends up happening is that we need a separate enzyme to remove that phosphate, which then allows the myosin head to be ready to do another contraction, which allows another muscle movement. And so it's only by removing this phosphate that we end up having a myosin head that's ready. In order for this to happen, the body needs to have calcium. Where this calcium comes from is through the calcium channel. So calcium enters in through the channel into the cytoplasm, and it also comes out of the sarcoplasmic reticulum. So there are two ways that we have calcium enabling a muscle contraction. what ends up happening with the beta receptor is the beta 2 receptor is GS linked. We know that the downstream effect of beta 2 is to produce cyclic AMP. Once we make cyclic AMP, what does it activate? What comes after cyclic AMP? Protein kinase A. Protein kinase A is a kinase enzyme, which, if you remember from biochem, the role of a kinase is to phosphorylize. So what pKa does is that it continues to phosphorylate the myosin head, and it does not allow it to dephosphorylate. So the kinase enzyme keeps the myosin head activated, which prevents the next muscle contraction. So in other words, we're keeping the myosin head in a inactive state. So what the beta 2 receptor does is it prevents the myosin head from being reactivated and causing a contractile force, or in other words, promoting relaxation. Does that make sense? Does anybody have questions on this? This is what I was looking for earlier, this diagram. All right. Why is this important to know? The reason why this is important is because we have beta 2 receptors in the lung and the blood vessels, which have major roles in medicine. In the lung, so we'll go back to this chart. We activate versus inhibit. In the lung, we are using beta 2 agonists in order to promote relaxation. Whereas if we inhibit the beta 2 receptor, we're going to decrease relaxation. Do we cause constriction of the bronchi by blocking beta 2? No, right? Again, this is this whole idea of what is the role of beta 2? It can only ever increase relaxation, right? By doing the opposite, we can only decrease its action. We don't cause the opposite to be true. It appears to look constricted, but we don't cause constriction. It's that same idea that if we inhibit rest and digest, we're not causing fight or flight. Same thing here, is that this appears to look like constriction. So what ends up happening is that beta agonists, we are going to use these guys for restrictive lung disorders, asthma, COPD, emphysema. Whereas the blocking beta-2 receptors is never beneficial in the lung. It is never beneficial. Why does it appear constricted? Because we are inhibiting relaxation, or we're decreasing relaxation. And remember, muscarinic agonists are causing constriction, right? So if you inhibit relaxation, then only the muscarinic receptors are going on, and then it looks like constriction. This means that this idea here for beta-2 blockade means that it can be decreased. I don't want to say decreased breathing, but bronchoconstriction, I think, is the best way of putting it. Bronchoconstriction. The other place that we end up finding beta receptors is in the blood vessels. And in the blood vessels, what we're going to end up doing is the same thing. We're going to increase relaxation of the blood vessel. Yes, beta-2. This is all about beta-2. Yeah. Right? Am I crazy? I feel like I'm crazy. No, I'm not crazy. Oh, maybe I did say it. And so what is the effect going to be in terms of beta-2 agonist would be a decrease in blood pressure, right? Whereas if you inhibit it, we're going to decrease the relaxation of blood vessels, which means that we're going to increase blood pressure. One of the big things I want you to understand about blood pressure is that blood pressure is a function of two major components. It's a function of cardiac output and total peripheral resistance. So total peripheral resistance is essentially talking about the diameter of the blood vessel, right? So if you have a blood vessel that is very, very constricted, you have more resistance. But if you have a blood vessel that is very, very relaxed, you have less resistance. So a more relaxed blood vessel will encourage a bigger diameter. So in other words, blood pressure is a function of the diameter of the blood vessel. The other thing is cardiac output, which the two big components here is heart rate and stroke volume. And we'll talk about that when we get to beta 1 in just a second. But for now, what I want you to be aware of is that why we talk about beta 2 in terms of blood pressure is its effects on total peripheral resistance rather than its effect on the heart. Does that make sense? Does anybody have any questions about that? All right. Couple of other things that we should know about smooth muscle in other areas of the body. One of the other places that we see smooth muscle being affected is specifically in the uterus. So in the uterine smooth muscle, we find beta 2 receptors. And what is going to end up happening here is we get increased relaxation of the uterine muscle. Inhibit it, you get decreased relaxation of the uterine muscle. You guys learned that why is this beneficial? Why would we ever want to relax the uterine smooth muscle? What would be a condition where we wouldn't want the uterus to push? A muscarinic antagonist blocks the constrictive ability of the muscarinic receptor. So an muscarinic antagonist, is going to inhibit constriction, which looks like dilation. A muscarinic agonist is constriction. Antagonist, bronchodilation. Exactly. Premature birth. So what ends up happening is that in some women, the uterus starts to push too early in the pregnancy. And what we use some beta 2 agonists is for tocolysis, or to prevent premature birth. Now, what is a potential contraindication of beta 2 antagonists? What's a potential contraindication for beta 2 antagonists? Hypertension, specifically in the uterus. Pregnancy, right? Pregnant people. If we gave, specifically here, we're talking about systemic beta blockade. Now, do we end up seeing this as an issue? Do beta blockers affect the contractility of the what am I trying to say? Do they affect the contractility of the uterus? Yes. But this is when we're not talking about like pregnancy, month 4. We're talking about they are in labor and we're trying to give a beta agonist, a beta antagonist. Okay. The only time that the uterus is going to start contracting is when it's trying to push out the baby. So if you were to slam someone full of propranolol while they're in contractions, you're going to make that much worse. All right. So specifically what this would be is in labor, where the uterus is already starting to push. Does that make sense? Okay. Can we use this effect of relaxing the uterine muscle? Could we use it for menstrual cramps? Would this be a good idea for menstrual cramps? Well, here's the first question. Would it work? Does the mechanism make sense? Yeah, right? We know that menstrual cramps is all about the uterine muscle squeezing. So anything that would relax that squeezing would be beneficial. The problem is that you'd have to give this drug systemically, which means that you're going to drop blood pressure like crazy, right? So it wouldn't be, while it would technically work, it wouldn't necessarily be the best option for someone. And so we'd want to go through a different mechanism. So we have other drugs that have less systemic effects than a beta agonist. Does that make sense? Does anybody have questions about that? Okay. All right. So 3 really, really big effects of the bronchial smooth muscle. The specifically, one of the side effects of these drugs, the beta 2 agonists, is their effect on the liver. Oop. And I just need to bring up beta 2 gluconeogenesis. Do-do. Mm-mm. Nope, that's not helpful. I'm not even sure he went into that much depth, so I'm not going to worry about it. So specifically in the liver, one of the big side effects that ends up coming with the beta agonists is we get increased gluconeogenesis and increased glycolysis. What the effect of this is that we get hyperglycemia. And so one of the relative contraindications for beta agonists is in diabetics. because now we're going to make their blood glucose release much, much, much worse. Right? The overall effect here is that we get, I think it's 2 to 3 times more glucose release. It's a huge amount of glucose, which if someone is using this infrequently, could definitely put them into ketoacidosis or a glycemic crisis. So definitely not a good thing about beta agonists. And I think that was really all the depth that he went into. I don't think he really went in any more depth than that. So I'm not gonna do any more. Oh, glycolysis? I think it's it's glycogenolysis. Great question. Can you induce labor if you give a non-selective beta antagonist? No, you're not going to induce labor. The reason is because that the body needs several cascading events in order to cause labor to begin. Uterine muscle pushing is one of the last things that ends up happening. You need a surge of oxytocin in the beginning in order for that process to start. So one of the things that we actually give very often in pregnancy is beta blockers, beta antagonists, because they have really beneficial properties for the mother in terms of controlling blood pressure and heart rate. So beta blockers are totally fine to give in pregnancy, but if they're in labor, not a good idea. You're going to make that process much worse. And what specifically is going to happen is that you're going to start pushing before the cervix has fully ripened, before it has opened. And now you're like squeezing this baby through a small hole, and it's just not good. You're really going to fuck up the kid. They're really, really bad. Great question, though. All right. So whenever you think about beta 2 agonists, what? We can kill 4 people a year. It's fine. Beta 2 agonists. Couple of things to bear in mind. They're used locally in the lung. Okay. All of the drugs that we give you for this exam, albuterol, levolbuterol, formoterol, salmeterol, vilanterol, they're all used locally for the lung via inhalation. Why do we do it via inhalation? What's the purpose of doing this route?
So it bypass first pass metabolism?
Yep, definitely. These drugs are highly metabolized. So no first pass. What else? Exactly. We decrease the systemic effects, right? If you're inhaling it directly into the lung, very little of it is getting absorbed into the blood where it's going to cause your blood pressure to drop, right? Imagine that you're having this asthma attack, you take your inhaler, and then your blood pressure drops so quickly that now you've passed out on the floor, right? That would be a terrible drug. Say, okay, now you can breathe, but now you're knocked out because your blood pressure is so low. Not a good thing. What else? What is another reason why we would do a local administration like inhalation.
Wait, so there will be systemic effects, but they are too low to be noticeable, or
Great
they
question.
wouldn't be?
Great question. By doing this local inhalation, by doing the lung, the doses are much smaller. So because we're giving it locally, we don't need to give as high as a dose in order to get the same response. So what that ends up meaning is that we don't get no systemic effects. We just get minimal compared. Does that make sense? Does that answer your question? Okay, sweet. The last part here is talking about increased local effect. So what does this mean? More action in the lung. Right? What's another way that we could get it into the lung? You take a big needle and you stab it right into the chest, right? You inject it, right? That would be a local effect. Not very great. Nobody's going to want to, put an 8-inch needle into their chest. Not many people are going to be capable, especially during an asthma attack. So the reason why we use it is because we're getting it right to where it needs to happen. Okay. We're putting it right where the drug needs to have its action. And because of that, we're getting a much greater effect overall, right? The way to think about this is if I have knee pain, I could take ibuprofen orally and it would go everywhere in the body, or I could apply diclofenac cream to my knee, which would have local anti-inflammation, right? So it's much, much better to do a local administration, which inhalation is local administration, than to do systemic. Does that make sense? Does anybody have questions about this? Great, 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 great. Did he talk about the eye? And yes, okay. Then we'll throw in the eye real quick. In the eye, you have a structure called the ciliary body. And the ciliary body is responsible for creating the aqueous humor, which is that jelly-like substance that fills your eye and provides ocular pressure. Beta-2 receptors in the eye, when stimulated, cause, it's humor because we're American, the beta-2 receptors in the eye end up increasing the aqueous humor. This is not beneficial because we're going to be increasing intraocular pressure. So what would be a contraindication of systemic beta agonist glaucoma? So someone who has super, super severe glaucoma, would you want to give them an albuterol inhaler? Probably not. Probably not a good idea, right? Because their eye pressure is going to get so messed up that they might end up, having a retinal detachment. Same thing here. If you block the beta-2 receptor, you're going to decrease the aqueous humor production. And so could we use a beta blocker as an eye drop? Yeah, Totally. 100%. So this is going to decrease intraocular pressure, which is going to treat your glaucoma. And there are really two drugs that we're going to be using in the eye. The first one is timolol, and the other one is, oh God, is it Nadolol? Or is it I think it, oh, I don't, oh, God. Timolol. I think it's Nadolol as well. I definitely know it's timolol, but I think it's Nadolol as well. I'm gonna put down Nadolol, but I will double check on that. So I'm not comfortable putting it down. I'm not gonna put it down. Definitely timolol. We use timolol all the time. Any questions about this effect on the eye? Okay. Gluconeo and glycogen. Just for completion's sake. All right. Let's move on to beta 1. Beta 1 is a what kind of GPCR? Does anybody remember what it's linked to?
You?
Not GQ. Not GI. It's GS. Very nice. But wait, I hear you say. Didn't GS cause relaxation? Yes. But we're talking, I don't think. When we talk about beta 2, this is GS linked, but only in smooth muscle. Beta 1 is GS linked, but specifically in cardiac muscle. Is cardiac muscle the same as smooth muscle? No. They have two completely different anatomies. So we're going to end up seeing the same similar function of GS, because a GS receptor is a GS receptor, but what it is acting on is going to be totally different. So what is going on here? What ends up happening is in cardiac myocytes, I just want to yes. In cardiac myocytes, just like before, what we are talking about is the myosin head, which, as we talked about, is using ATP to cause that muscle contraction. It's slightly different. But we end up getting the same sort of idea. So we're constantly going through this cycle of phosphorylation and dephosphorylation, which is causing the stroke of the heart, right? Every time the myosin head has this phosphate group attached, we have a beat. What we need to happen here is we need calcium to enter into the cell. One is by the sarcoplasmic reticulum, but what we also have going on the surface of cardiac cells are two different ion channels. The first ion channel, let me use a different color. Calcium. The first ion channel is the T-type calcium channel. The T-type calcium channel is a T-type? L-type. T would be troponin. L is myocyte. Okay, so it is L. Yes. J-type. That is right. L-type. The L-type calcium channel requires a phosphate to open. So when it has a phosphate group attached to it, it opens, allowing calcium to flow into the cell. Great. Fantastic. When we go to our beta receptor, so we have our beta 1, which is GS linked. We know that the GS is going to cause CAMP production, which is going to activate protein kinase A. And just like we talked about before, the role of protein kinase A is to phosphorylate things. What do we think protein kinase A is phosphorylating? Is it going to phosphorylate the myosin head to prevent additional contractions? Exactly. It is going to phosphorylate the calcium channel to keep them open. So this keeps the calcium channel open longer. What is the overall effect of having more calcium in the cell? What does this end up doing? Not depolarizing the cell. Yes, chromo, dromo, I know things. Which one? I know. Yes. We get increased inotropy, which is the same thing as saying increased contractility. Remember, calcium is all about muscle stroke, right? And so we're increasing the stroke force of the muscle cell. So it's squeezing harder because it has more calcium to cause the myosin head to phosphorylate. Does that make sense? Any questions about that? All right. The other thing that it does is it phosphorylates the funny channel. What kind of ion is the funny channel? What comes into the cell? Not potassium. Good guess, though. Sodium. Very nice. Sodium enters in, and what ends up happening is we end up getting we keep the funny channel open longer, which means that we're going to have more sodium influx, which means that we have more depolarization. I like how I'm writing at an angle here. What is the overall effect of having more depolarization? We have increased, exactly, more activity, so we have more chronotropy. In other words, we increase the heart rate. We also increase the dromotropy. We increase the conduction velocity. So this is why beta 1 activation causes these inochromodromo effects. One is it's affecting the calcium channel, which is going to increase the contraction. The other is that it's opening the funny channel, making it depolarize more quickly. Any questions about this diagram? The funny channel. NAF is the funny channel. That's just my abbreviation. I think there's a specific abbreviation, but I just can't remember it. Yes. Yes, funny channel on the SA node. Yep. Good question. The difference between phosphate and phosphorylate. Phosphorylate is the process of adding that phosphate group. So if you remember back from biochem, when we talk about ATP, what we have is that adenosine backbone, and it's connected to 3 phosphate groups. And what ATP does is that it loses one of these phosphate groups in the process of it opening one of these channels. So it literally sticks one on and keeps it open. Almost kind of like you're putting a door stopper in the door to keep it open, right? So ATP is required for all these actions, which is why it has to go through CAMP, and then phosphokinase kind of makes it happen. No problem. All right, let's quickly talk about the, oh, no, it was already at the bottom of that layer. That's why. Oh, no, never mind. The other place that we see beta 1 receptors is on the juxtaglomerular cells. Or in other words, the kidney. What ends up happening here, and I just want to Did you guys learn about the renin aldosterone, renin angiotensin aldosterone? Okay. Okay, sweet. Do, do, do. Yes. Okay. What ends up happening in the kidney is that you have your beta 2 receptor, which we know is linked to GS. This is going to increase CAMP production, which would then cause, yes. Oh, God. Beta 2. Come on, Gabe. Beta 1. Thank you. We're going to increase CAMP production, which means that we're going to increase protein kinase A action. What ends up happening through beta 1, specifically in the kidney, is we have the production of renin. Now, when you guys learned about the RAS system, what is important to know about renin is that this is going to how do I want to say this? Renin goes through the I don't want to confuse you guys. Renin will get turned into angiotensin 1, where it then goes through a second enzyme called angiotensin converting enzyme, or ACE, where it gets converted into angiotensin 2. And where the money comes in is where angiotensin causes aldosterone to be released. Does anybody remember what the result is of aldosterone being released in the kidney? Yeah, sodium related things. So we end up getting sodium retention in the urine. And water retention. Now, if you have more water being kept in, not in the urine, in the blood. If you have more water in the blood, that means that you're increasing the blood pressure, right? You have more stuff flowing through the blood. So the ultimate effect here is an increase in blood pressure. Now, why do we care about this? Why is this something that is important to understand about beta 1 receptors? Well, we go back to our understanding of blood pressure that we talked about earlier. We said that blood pressure is a function of cardiac output and total peripheral resistance. We said that total peripheral resistance has to do with blood vessel diameter. Whereas cardiac output was a function of stroke volume, which is contractility, and heart rate. Which is a function of chronotropy and dromotropy. So, beta 1. Does beta 1 affect cardiac output? Does
No.
Does beta 1 affect heart rate?
Yes.
Yes, it does. We know that it has a chronotropic and a dromotropic effect. Does beta 1 affect contractility? Inotropy? Yes, right? That's all mediated on the cardiac myocyte, where we talked about before. Does beta 1 affect blood vessel diameter? No. But would it affect total peripheral resistance? Yes. Why? Because we're retaining fluid. We have more volume in the blood. More volume means that we have more arterial pressure, which means that we have increased blood pressure. So beta 1, when you think of beta 1, what is the overall effect? Increase blood pressure. It is affecting the cardiac output and it is affecting total peripheral resistance. How? Part of it is through its effect on the heart. Part of it is through its effect on the kidney. So whenever you talk about turning on beta 1, what are you immediately going to think about? Increasing blood pressure. Increasing the action of the heart. Any questions about that? Does this make sense? Dromotropy is conduction velocity. So how quickly it travels from the SA node to the AV node to make the atria, then the ventricles contract. And if they're not talking to each other, then you end up with an arrhythmia, like AFib or SVT, supraventricular tachycardia. All right. Was this helpful to go through all the physiology, by the way? Again, like if I'm talking about things that you guys don't care about, let me know. Okay. All right. Let us quickly talk about the drugs. And then we'll be in an okay place. Um, oh. Perfect. All right. The drugs. Favorite thing in the world, right? We have two categories of beta drugs. We have our agonists and we have our antagonists. We also have two categories in each one. Here we're going to talk about both. It'll make sense in a second. We have selective and we have non-selective, selective, and non-selective. So what we're going to do is we're going to talk about the two different categories, beta 1 and beta 2. Do we see how this is set up? Would this be better if I did it in like Excel? Would it be more clear? Okay. All right. All right. Let's first talk about our beta 1 selective agonists. So beta 1 is primarily where? The heart and the kidney. Heart and kidney. So if you turn on beta 1, you are going to cause an increase in blood pressure. You are going to increase heart rate. And you are going to increase stroke volume. Which again, remember that stroke volume is how hard the muscle is contracting. All right. What are some of the indications for the beta 1 selective, which I believe he's only teaching you one, which is dobutamine. What is the indication of dobutamine? There are instances where we have where the heart isn't beating fast enough or hard enough. Okay. So the heart rate is too slow. Bradycardia. Or the stroke volume is too low. So the heart isn't not contracting hard enough for that blood to leave the heart. And so this would be heart failure. Which the definition of heart failure that I want you guys to think of is about how the heart is tired. It's so tired, it's not able to pump the blood out of the ventricles. So by giving dobutamine, we're going to cause it to pump harder. How many do we want to, for someone who has heart failure, so their heart is tired, Do we want to give dobutamine for a long time?
No.
No, right? We give dobutamine in cases where we need the heart to pump harder for hours to maybe a day or two. If you give dobutamine long term to someone with heart failure, even someone with a normal heart, you are going to tire that heart out, and you're going to exacerbate heart failure. Okay, so dobutamine is a short-term drug. The other thing that we're going to be using it for is on the juxtaglomerular cells. We are going to want to increase volume. Blood volume. And the reason for this is that for whatever reason, the blood pressure has dropped really, really far. All right. Usually this is because the blood vessels have become so dilated that the heart is pumping really, really fast, right? It's beating as fast as it can, but because the blood vessels are so dilated, it's not generating any blood pressure. And this would be in the case of shock. In shock, your blood vessels have dilated hugely. And so we want to increase the amount of fluid that the body is retaining, so that way we are increasing the blood pressure. Any questions about these indications? All right.
Oh,
Nope.
so also bradycardia, heart failure, and shock are why you would use dobutamine?
Yes, the uses. Yep. The indications. Now, in terms of adverse reactions, whether we have selective or non-selective, we're going to have the same adverse reactions. Which I think he gave you guys as isoproterenol. So isoproterenol has the same indications. Same indications as the selective. But in terms of adverse reactions, we are going to have things like tachycardia and arrhythmia, tachyarrhythmia. So what would be a contraindication to using a selective or non-selective beta agonist? What would be, thinking about this tachycardia or tachyarrhythmia, what would be a potential contraindication?
Hypertension?
Yeah, you wouldn't want to use these drugs in hypertension. You're going to cause it to skyrocket. But you wouldn't want to use it in something like AFib, right? Atrial fibrillation is where the atria are fluttering, right? They're pumping so quickly. So you wouldn't want to give a drug that's going to start causing that heart rate to go up and become more out of sync. So AFib is a type of tachyarrhythmia, so you wouldn't want to give dobutamine or isoproterenol in a condition where they already have a tachyarrhythmia. Would not be a good idea. And then just like Pierre said, and I should have put it down, hypertension. Big, big bone. All right. In terms of selective, beta 1 selective antagonists, which these are going to be your beta blockers. It is very important to know which drugs are selective for beta 1 and which are non-selective. Okay? Oh. I meant to open these up. Because non-selective means that it's choosing both beta 1 and beta 2. Beta 1 and beta 2. Did he give you a list of which ones are beta 1 selective and which are beta non-selective? Maybe. I can list them out. Oh, he did? Okay. All right. Then I won't. In terms of beta 1 selective drugs, primarily what we are using them for is to decrease heart rate. Beta 1 has a major effect on the cardiac myocyte, and to some degree we are using them to decrease blood pressure. Now, by blocking renin, we're not going to suddenly start dumping water out of the body. There are multiple other factors that are controlling the amount of water in the blood vessel. So this is a smaller effect, but it's still something that we should account for. So when you think beta antagonists, what I want you to think is decreasing heart rate, and to a lesser extent, decreasing blood pressure, also decreasing stroke volume. Does that make sense? So big effect on decreasing the action of the heart, smaller effect on what the kidneys are doing. In terms of indications here, so the uses of beta blockers, whether they're selective or non-selective. First thing you're going to see is heart failure. Why do we want to use beta blockers in heart failure?
Because the stroke volume is low?
Yeah, exactly. We want to reduce the strain on the heart. So heart failure is all about how the heart is tired. It doesn't like having to pump so hard against this really high blood pressure usually. So what we end up doing is we give antihypertensives like ACE inhibitors or diuretics to lower the blood pressure, but then we also need to reduce the stroke volume in order to reduce the stress on the heart. So one of the major indications of beta blockers is heart failure. You'll also see it being used in arrhythmia. Specifically, what kind of arrhythmias? Are we talking about tachyarrhythmias or bradyarrhythmias? Tachyarrhythmia, exactly. So we're talking about AFib and supraventricular tachycardia. And then finally, one of the last things we're going to use it for is hypertension. And then also something called acute coronary syndrome. ACS, acute coronary syndrome. Non-selective beta blockers, same indications, right? We're still going to be using them for heart failure, tachyarrhythmias, different stuff like that. And they're going to have very similar adverse reactions because they're working on the beta 1. And so what are we going to end up getting? We're going to get bradycardia. We're going to have slow heart rates. You could potentially cause hypotension, so low blood pressure. By the way, this is a shorthand for hypotension. And then in terms of contraindications for the selective or the non-selective here is we have, let's talk about the absolute contraindications, so where you should never use them, is first of all, decompensated heart failure. Decompensated heart failure is where we're reducing the strain on the heart, and the heart says, oh, great, I don't have to do anything ever again. I just love being turned off. And so you shouldn't give a drug like a beta blocker to someone who's has decompensated heart failure because you're just going to turn the heart off and then they die. The other one is pheochromocytoma. Why don't we want to give beta blockers, especially non-selective beta blockers, in pheochromocytoma? No problem. Pheochromocytoma is that tumor that in the adrenal gland that releases tons of norepi and epi. So if you're by giving a beta blocker in no, that doesn't make any sense. No, this doesn't make any sense. You would want to use it in pheochromocytoma. Disregard what I'm talking about. Dumb. Dumb, dumb, dumb. Other things, which we'll talk about in just a second, because they have to do with beta 2. All right, let's go into beta 2, and then we'll wrap up. Beta 2 receptors. All right. Our beta 2 selective agonists. These guys are going to be causing bronchodilation primarily. And Do, do, do. Ba, ba, ba. So that's really the only thing. Oh no, and then bladder smooth muscle relaxation. I will talk about the bladder in just a second. I know we have to go through beta 3. We're going to run over just a tiny bit, so I apologize. So those are the two big effects of beta 2 receptors. Because of these effects, the indications for using a beta agonist are going to be for asthma and COPD. Oh, and there's one more that I'm missing. And decreasing aqueous humor production. So the indications are asthma, COPD, and glaucoma. No, I'm getting them all mixed up now. I was right originally. That's beta blockers. I'm crazy. So when you think beta 2 agonists, what I want you to think is inhalers. We're really only going to be using them for their effect on the lung. Everything else is an adverse reaction. Yes. Yep. So in terms of beta 2 agonists, really we're going to be using them for this. There are certain drugs that we use, like for tocolysis, which is only terbutaline. Only terbutaline. But in terms of beta 2, everything else is going to be an adverse reaction. So we're going to have bladder smooth muscle relaxation, which is going to cause urinary incontinence. Good question. Would we want to use this for urinary retention? So someone who's not peeing, would we want to use a beta 2 agonist? No, because of all the other adverse effects. So remember, systemic beta 2, no good. It is not great for the body. Good question, though. We're going to end up increasing glucose release, which means that we're going to cause glucose fluctuations. And then finally, we're going to increase aqueous humor production. Which means that for our beta 2 agonists, our contraindications are going to be things like urinary incontinence. So if someone is already incontinent, we do not want to give them, it would be bad to give them a systemic beta blocker. Diabetics. Oh, yes, that is a better way of phrasing it. Urinary retention. No. Yes, continence. No. Causing relaxation, which is going to cause you to pee more. So we have urinary relaxation, which is going to make you incontinent. Yeah. So this is urinary relaxation, urinary incontinence. You're not retaining urine. You're incontinent. Right? Or am I crazy? No, incontinence. No. So it when we're talking about smooth muscle relaxation in this case, we're not talking about the detrusor muscle. You're thinking of beta 3. Beta 3 is all about the detrusor muscle. Beta 2 is the sphincters around the neck of the bladder. Yeah. Alpha is there as well. Yeah. We will go through the bladder stuff when we talk about alpha. Okay. I promise you, this will all get cleared up. I promise. Okay. Don't worry about this. Focus on the other stuff rather than the bladder. I promise you, I will get you there. So, urinary incontinence, diabetics, and then obviously glaucoma. Not good stuff. Okay. Beta 2 antagonists. What kind of beta? So we know that over here we have things like albuterol, salmeterol. It depends on where you're relaxing. That's the thing. Yeah. I'll show you guys a diagram when we talk about beta 3 in just a second. I promise you. There are no beta 2 selective antagonists. Okay? No beta 2 selective antagonists. We don't have any. Why would we not want any beta 2 selective antagonists? Well, it has to do with the adverse reactions. Okay? So what is going to happen if you block beta 2? You're going to cause bronchoconstriction. You're going to cause decreased glucose release, which is still going to cause glucose fluctuations, right? But instead of sending someone into hyperglycemia, now we're going to send them into hypoglycemia. So instead of them being presenting as like this drunk person, now they're just going to be passed out on the floor and probably die. Not great, right? So in beta agonists, we're causing a fluctuation into hyperglycemia, whereas here we're causing a fluctuation into hypoglycemia. This means that what contraindications are we going to have? We're going to have things like diabetics, and we're going to have things like asthmatics, severe asthmatics. Not like, oh, occasionally I have to use my inhaler. It's like every day I have to use my inhaler or else I will die. That sort of stuff. Oh, I meant to put them up there. These are relative contraindications. Another one that you'll see is Raynaud's disorder, Raynaud's disease. Does anybody know what Raynaud's is? Cold fingers, yeah. So what happens in Raynaud's is that the blood vessels in the blood vessels in the fingertips or in the oh, you have Raynaud's. The blood vessels in the fingertips constrict, causing them to get really, really cold and they get discolored. This can happen usually because you go outside and your hands get cold. And so it triggers this response. Why is this a contraindication for beta blockers? Why shouldn't you give Sarah a beta blocker? Exactly. Beta blockers cause constriction of the blood vessel, right? So with someone with Raynaud's, you're going to end up constricting the blood vessels even more in their fingers, which is going to make the problem worse. And then they lose their fingers, and then we have to call her No Finger Sarah. What I will say is that for the there is one indication specifically for beta 2, and it is in glaucoma with the drug timolol. So timolol is a beta 2, beta non-selective, but we use it specifically for its beta 2 action. All right. Any questions? All right. Real quick, I just remembered an acronym that I use to remember the beta 1 selective antagonist, and it is MANBABE. Metoprolol, atenolol, nebivolol, bisoprolol, atributolol, betaxolol, and esmolol. These are all the beta 1 selective beta blockers. So if you are not a MANBABE, you are non-selective. Okay. All right. Do we want to finish beta 3 tonight, or do we want to just do it another time? What would you guys prefer? You would like to sleep. Okay. What I'm going to do is I'll record a little section about beta 3. It's really not that bad. And I'll let you guys go. Because we went through a lot of stuff today. I know that much. All right. Take care, everyone.
All right, thank you, Gabe.